Goed, dames en heren. We gaan over naar een serieuzer zaak. Naar onze keynote-spreker Stefan Hofmann. Hij vroeg me om het op zijn Duits uit te spreken. Hij is Duitser van origine. Hij woont al een hele poos in Amerika en is daar inmiddels een zeer gerenommeerd onderzoeker. Echt een wetenschapper van naam en faam. Bovendien is hij zeer direct betrokken geweest bij de totstandkoming van die DSM, de DSM-5. Hij is ook nog voorzitter van de Amerikaanse Vereniging voor gedragstherapie. En hij is een bevlogen behandelaar. Ik weet niet of u zijn workshop heeft bijgewoond vandaag. Nou, ik wel. En je denkt echt, hoe is het mogelijk? Zo bevlogen. Hij werkt met mensen met sociale angst en zoekt echt de grenzen op in zijn vak. We gaan heel graag luisteren naar Stefan Hofmann. The floor is yours.
Thank you. Thank you. Thank you much. Well, thanks a lot. It's a pleasure being here. I'm quite impressed by this organization. Really wonderful. So, thanks for giving me the opportunity to discuss the future of CBT in the age of the DSM-5. And I should mention that I was part of the DSM process. I was an advisor only, so all I did was criticize. I did not really write the DSM-5, but I was able to complain about a lot of things. So when we talk about diagnosing mental disorders, or any disorder, we often use the phrase carving nature at its joints. And in the spirit of the season in the United States, we have Thanksgiving coming up. So just imagine this turkey that you cut into meaningful pieces, and then you have end up with these distinct features, and the family is fighting over some of them. And just as we do this with the turkey, we're trying to make sense of the complexity of human nature and split this complexity into meaningful chunks, into categories of the DSM-5. Now, why do we diagnose mental disorders? Number of reasons. We need to have a common language. We need to be able to refer to the same problem. We don't want to call up a colleague psychiatrist and list all the symptoms, but rather we have one word that describes a particular problem. We need a code for all sorts of different reasons, insurance companies included. We obviously want to advance science. This should not just be a book, not just be a language, but rather we are hoping that by classifying disorders, we understand the nature of psychopathology better, and then also understand treatment approaches as well. So we'd like to optimize tailor existing treatments to these classifications. Now, there's a lot of criticism around the DSM-5. You're certainly all aware of it. There's clearly clinical utility, and the authors of the DSM-5 acknowledge that. It's useful to have this language, but they also, it was also acknowledged in the DSM-5 there is a lack of concurrent and predictive validity. In other words, these disorders don't really match nicely onto any particular biological markers, neuroscientific, neuroscience correlates and the like, and they can't really be used for treatments either, at least not in a meaningful way. There's a recent initiative in the United States, and you might have heard of it. If you haven't heard about that yet, you will hear about it very soon. It's called RDoC, stands for Research Domain Criteria. This is the idea that was proposed by the head of the National Institute of Mental Health, Tom Insel. He said, I do not want to see any more grant proposals that are trying to validate DSM categories. He's the head of the major funding institute in the United States. He says, if the grant does not inform what I call RDoC, Research Domain Criteria, then you should go to other funding agencies. There are none. You could go to American Psychiatric Association. Maybe they'd like to give financial support to validate DSM categories. The idea of RDoC is to identify basic dimensions of functioning across a multiple range of multiple units of analyses across different DSM diagnoses. The goal here is to specifically translate biological and neuroscience findings into treatment approaches. Today I'd like to share with you some thoughts that inform the classification, it might inform classification, also treatment, using what we know best, cognitive behavioral therapy. I think CBT can contribute to that very controversy. It can not only inform treatment, obviously it does, because it's a treatment approach, but we might be able to use it also as a way to classify individuals in the future. CBT is the big success story in treatment, in the field of treatment research, generally speaking. This is a list of meta-analyses, not single studies, but meta-analyses published throughout the years. It's pretty dramatic. As you can also see, this is difficult to see, but just to point out, the various meta-analyses target different DSM categories. We have meta-analyses for, and also studies obviously for anxiety disorders and depression, chronic fatigue syndrome. They all are targeting DSM-defined categories. This is actually quite remarkable that we are able to get some pretty good effect sizes using a fairly arbitrary medical model idea with splitting people based on symptoms that share, that show a great degree of variation in ideology and in all sorts of other dimensions. Yet we are able to treat individuals who belong to the same diagnostic category fairly well. At the same time, there's significant room for improvement. This happens to be one of my area of research. This is anxiety disorders. And this is one meta-analysis that examines the efficacy of cognitive behavioral therapy for anxiety disorders, ranging from acute stress disorder, obsessive compulsive disorder, and the like. I just want to point out that we are doing okay. All of these effect sizes are in fact statistically significant, but there's still quite a bit of room for improvement. And also, we are, as we treat anxiety disorders, other symptoms improve as well, such as depression. There's not much treatment specificity in our interventions. The same is actually true in terms of how strong the effects are. The same is true for medication intervention. This is a efficacy of SSRI for anxiety disorders. And similar to cognitive behavioral therapy, the effect is in a moderate range. There's still significant room for improvement, but it's statistically significant as compared to placebo. When we compare, now one approach is obviously to compare two mediocre treatment, to combine two mediocre treatment might result in a better intervention than either of those monotherapies. So CBT is decently effective, SSRIs are decently effective. If you combine those, you should get a better treatment response. This is not the case. For panic disorder and generalized anxiety disorder, comparing cognitive behavioral therapy plus pharmacotherapy versus cognitive behavioral therapy plus pill placebo only gets you a moderate size effect. Same is true for obsessive compulsive disorder and social anxiety disorder. Actually, the effects are even smaller, small or even non-significant. This happens to be one particular study that compares cognitive behavioral therapy plus versus fluoxetine versus as an SSRI versus CBT plus fluoxetine versus CBT plus pill placebo versus pill placebo. You see all four active conditions are similarly effective. The combination is not more effective than either of those monotherapies. It seems like if you need to give a pill to cognitive behavioral therapy, you may as well give a sugar pill. You get the same effect. Now, why is that? And it gets me to the next step. How can we possibly improve upon cognitive behavioral therapy? One is One possibility is state-dependent learning. Individuals who learn something when they undergo cognitive behavior therapy but are under the influence of a particular substance have problems retrieving this new learning because they're now under a different state if you take away the drug. Or perhaps it's attribution. Perhaps if you give people a pill and they are able to do that, to do whatever task you ask them to do, they attribute it to the pill rather than to their skills. And you take the pill away, they feel like, oh, I don't have the pill anymore, I probably can't, I won't be able to do it, so they relapse as a result. Or perhaps it's turtle race. Let me explain what I mean by turtle race. So you have one turtle. We call this turtle pharmacotherapy. And we have another turtle. We call this turtle cognitive behavior therapy. And we are trying to get to a goal, which is treatment response. And I say, okay, start now. Both turtles are quite slow and eventually reach the goal, but it takes them a long time. Now, how about we do something else? How about we speed up one of those turtles, which is cognitive behavior therapy, and put a rocket on it and say, okay, start. As you can see, the one with the rocket reached the goal much, much faster. I'm going to now tell you about a way to speed up your turtle, which meaning how to speed up, facilitate cognitive behavior therapy with something that we call cognitive enhancer. And in the second part of my talk, I will also tell you about prediction of how we can predict response to cognitive behavior therapy. This discussion will cut across DSM diagnoses because we now will rely on neuroscience findings. And it will also allow us to segregate groups within a diagnostic category of people who may and those who may not respond to treatment. And when we talk later about prediction, similarly, we're able to split people who are belonging to the same diagnostic category into meaningful subgroups. So how can we augment cognitive behavior therapy? Our cognitive behavior therapy is a learning process. You learn something. And I have to share a little bit of the neuroscience background of learning. The glutamatergic system, the NMDA receptor, is quite important when it comes to learning. NMDA stands for N-methyl aspartate receptor, and there are two molecules that bind to a receptor unit. One is glutamate, and one is glycine. Once these two molecules bind, and the cell communicates something to the other cell, calcium channels open up. Calcium goes from the outside to the inside of the cell, and long-term potentiation occurs, which is the biological basis of learning. D-cycloserine is a substance that happens to be a fairly safe substance for people to use, especially in small dosing, that binds to this glycine receptor side unit, and it has the characteristic that it leads to the opening of a little bit of the channels to be a little wider, and a little bit more calcium comes in, and a little bit more long-term potentiation occurs. That means learning is being sped up as a result of D-cycloserine. This happens to be one of the early studies that in which we examined the efficacy of cognitive behavior therapy for anxiety disorders. In this small trial, we randomized people to either receive a brief course of cognitive behavior therapy, 5 sessions, and gave them a very little dose of D-cycloserine just an hour before the exposure session. The other group received pill placebo. There's a very small dose, only 50 milligrams. And I mentioned to you that it's a safe drug. Typically, D-cycloserine in the past, or it is being used as an antibiotic to treat tuberculosis. However, you have to take a lot more to get the antibiotic effect. So you do not get an antibiotic effect with only 50 milligrams. You have to take about 1,000, 1,500 milligrams over a longer course of treatment, and then you get the antibiotic effect associated with a lot of unpleasant side effects, however. 50 milligrams leads to virtually no side effects. People cannot tell whether or not they get the pill or not get the pill, whether they got placebo or not. Therapists couldn't tell. Assessors couldn't tell. What you find was, however, that if you give this small dose, just on 4 different occasions an hour before the exposure, the the learning is enhanced in such a way that people with decyclosurin respond more than those who receive pill placebo before cognitive behavioral therapy. Interestingly, if you take away the drug now and just follow them up, you get a stronger effect at 6 months follow-up, suggesting that has to do with memory consolidation rather than something happens during learning, but decyclosurin leads to a greater degree of learning. The learning is enhanced. This was a small trial. A number of other small trials appeared in the literature, and we recently completed a large-scale study that the question obviously is, well, if this works with a small sample with a truncated 5-session intervention, does it also work with a full course of CBT? This is the trial that we recently completed. We found, and I'm not going to go into detail, but just to point out that our cognitive behavioral intervention was actually quite effective. About 80% of people responded. Whether or not they got decyclosurin or pill placebo was irrelevant. CBT was very effective. Those who received decyclosurin improved a little bit more, but the difference in response rate was not significant. However, they responded faster. We administered decyclosurin at session 3, 4, 5, and 6. And as you can see, once we gave this drug, the people who received it responded much quicker to the intervention than those who received pill placebo. Eventually, the response was similar at the end, but the trajectory was a lot faster for those who received decyclosurin. Now, it brings me back to the DSM issue again that I discussed earlier. Now, can we possibly use that information to form meaningful groups of patients within our category called social anxiety disorder? So the question we asked, can we identify people who will and who will not respond to decyclosurin? Perhaps they form meaningful groups that can be used as a diagnostic tool that then also predict treatment response. One important implication of the model that I presented, how decyclosurin works, is that there has to be the extinction, the exposure has to be successful. Otherwise, decyclosurin will not do what you're hoping for it to do. In fact, we know from the rat literature that if you stop the exposure prematurely when the anxiety or when the fear level is still high, you get the opposite effect. You can get memory reconsolidation. Decyclosurin, in other words, can make good exposure better, but it also can make bad exposure worse. It's not a wonder drug, not a miracle drug. It works on has a very limited and narrow therapeutic range, but it opens up the mechanism of treatment research, and it provides us with a new way of grouping people into meaningful categories now. That's exactly what we find now. So people who show during the exposure, as a result of the exposure, a clear drop in their fear ratings during the exposure, for those individuals, decyclosurin has this added effect. For those for which the fear rating was on a moderate range still, on a 0 to 100 point scale, who had a 50 rating, the effect was clearly weaker, and even and the weakest if the fear still remained high as a result of the exposure. We went back to other data and found a very similar effect in numerous studies. And that, again, I repeat what I just said earlier, decyclosurin makes good exposure better and bad exposure worse. This is the same what we found with in another trial with height phobia. Again, individuals who received pill placebo but had still a heightened level of anxiety. For those, pill placebo was better than decyclosurin. For those who received decyclosurin but had a nice drop in anxiety, for those, decyclosurin was better than pill placebo. We did another trial with post-traumatic stress disorder. We were surprised why the effect was still so high. I know here in the Netherlands, people have been using decyclosurin also with post-traumatic stress disorder. We found different effects. We actually found that decyclosurin makes things worse. Now, I've been one of the engaged in the early research, I had no interest in finding negative results, but that's what we observed. We went back to the data and found again that for those individuals who had still a heightened level of distress during the exposure, D-cycloserine made it worse. Let me switch to the second part to my second part of my talk, which again points us to more meaningful ways how to classify individuals, which has to do with prediction. And again, cognitive behavior therapy can lead the way. Can we predict cognitive behavior therapy based on neuroscience measures? We recruited a large number of individuals with social anxiety disorder, and we asked the question, based on their neuroimaging at pre-test, can we predict whether somebody will respond to cognitive behavior therapy or not? This again might allow us to use fMRI as a way to diagnose individuals into new meaningful groups that then can be used as a treatment, as a way to assign people to treatment conditions. People were in the magnet and saw either emotional scenes, neutral scenes, emotional faces, neutral faces, or other scenes. And all they had to do is a very standard fMRI task. They're seeing these pictures, and they have to decide whether or not a picture that they are seeing now was present before. It's called an a one-back task. What we found was quite remarkable. We were unable to predict treatment outcome based on any other meaningful variables. Socio-demographic data, even pre-test symptomatology, any other diagnostic information. Nothing really we weren't able to predict treatment outcome with any other indicators. But neuroimaging was a very strong indicator, a very strong predictor. In particular, to response, angry versus neutral faces. The more people responded in their occipital clusters, in the dorsal occipital cluster and ventral occipital cluster. This is typically the area of the brain that processes, well, not surprisingly, faces, but also has to do with emotional processing as well. The stronger the activation in the comparison angry versus neutral faces, the more people will respond, and quite a lot more. We can predict it to a high accuracy. The explained variance is actually more than 40% of the variance we can explain based on these neuroimaging findings. So on the y-axis showing the changes in the Liebowitz Social Anxiety Scale, a scale that measures social anxiety, as we predicted based on these neuroimaging data. On the x-axis, what we actually observe. Obviously, we are confined within one sample. And the best, obviously, approach would be to use the same algorithm and to test it now in a completely different sample. We used, however, something called a leave one out cross-validation. So this is a way of getting around it by calculating this algorithm, taking one subject out, recalculating the algorithm, putting the subject back in, taking another subject out, and so forth until you reach sort of a relatively error-free, it's still errors involved, but error-free prediction. In other words, what I just said, on the left, these are, if you get an activation like that in the brain while people watch these kind of faces, that predicts good treatment outcome. On the right, it predicts bad treatment outcome. Again, this opens up a whole new way of merging neuroscience and pharmacotherapy and pharmacology and cognitive behavior therapy and nosology. There's no need to have 2 separate or 3, 4 separate ways of making sense of human suffering, but rather we want to use nosology and classification to inform treatment, and neuroscience can tell us a lot about it, and pharmacology can tell us a lot about it. So to summarize briefly what I have been saying, number one, we need to augment, in order to augment treatment, we need to speed up the turtle. Cognitive behavior therapy is quite effective. We can be proud of what we have accomplished, I believe. At the same time, there's significant room for improvement. And again, I'm surprised that we're doing as well as we are doing, because these are very arbitrary categories we're dealing with. Yet we can treat depression, anxiety disorders, substance use disorders quite well. But each of these categories are enormously heterogeneous. In order to improve CBT, therefore, we really need to tailor and subgroup individuals on a meaningful basis. Decycloserine can facilitate that process. Also, neuroscience can facilitate this process. We can predict treatment outcome using fMRI. This is only one first step, and I'm sure there are other technologies that will be more useful, more valid, but yet this is sort of a first step for the future to embrace neuroscience, pharmacology, biology, even genetics, and cognitive behavioral therapy in order to improve human condition. So what I think is the future, we need to actively participate in the scientific progress that moves mental health care forward. We need to be a very important voice in that. We meaning therapists who practice cognitive behavioral therapy and scientists who investigate it. We need to expand and quite possibly also change our paradigm. We need to bridge, not stay within our own little discipline. That also forces us obviously to study things that we don't know much about, but that's the nature of things. We need to cross disciplines. We need to let go of also turf battles, such as cognitive versus behavioral, or CBT versus third wave, or psychiatry versus psychology, etc., or neuroscience versus clinical psychology, etc. So we really need to work very closely with neighboring disciplines, and I think particularly important is the collaboration with neuroscience and biology. I think these are our friends. And I know neuroscientists do like CBT because that fits often with their model. We need to embrace those folks. We need to study them. We need to, I mean, not study the researchers, but we need to use their paradigms and combine our research. Finally, that's how I started my talk. We need to rethink the way we classify and treat disorders. Syndrome-based classifications are of limited importance. We are way behind other ways of classifying when it comes to, say, medical disorders. If you, Tom Insel, who introduced the research domain criteria idea, gave the example, you know, if you have a skin rash, people and go to a doctor, they will obviously know why you might have a skin rash, but he will examine you carefully if this is an unusual skin rash. It could be a very dry skin, and you would just get moisturizing cream. It could be an allergic reaction. You would get some cortisol. It could be a sign of a serious disorder if you have other rashes on your body. It could be a tumor or some other abnormal growth, and you would have you would get a test to study for that. You would have laboratory tests to inform the diagnosis. What are we doing in psychology and psychiatry? We're asking people questions and they're answering questions. That's it. We are basing them on, you know, when did you have these feelings and since when do they occur and so forth. This is a purely descriptive way of making sense of the complexity of human nature. We do have the tools to study other things. We have an fMRI already available. We even have other psychophysiological tests we could theoretically be using, but for some reason we don't want to do that. We have segregated a field of nosology and classification completely away from psychobiology, neuroscience, and also treatment. Again, treatment can inform, as I hope, this is a strong rain. Treatments can inform the classification of these disorders by simply making sense of it. So in this case, I would argue there are some individuals who should not be combined with others, quite simply because we know some individuals respond to one treatment better than to the other. So in the next step, we might even be able to assign people based to pharmacotherapy versus cognitive behavior therapy, or perhaps different forms of cognitive behavior therapy. Perhaps some people will respond more to mindfulness, others more to more behavioral-based approaches, etc., based on a test that we do with them before intervention. And the kind of questions we're asking them only provides us with so much information. Well, thank you very much for your attention. Shall I leave it on?
Wow, yeah, please, leave it on. We will need it with this rain, this heavy rain. Would you care for a drink?
Sure, sure.
Thank you so much for your really wonderful presentation. Maybe it's nice to look into the enhancers a little bit further, because it's really fascinating, I think. You state that psychotherapy is a form of learning, and we can enhance that learning with a very simple pill, a learning pill. Can we already consider this as a common intervention, a regular treatment, or is it still in an experimental stage?
I think we're still not quite there yet to go public with it and to go broad-based intervention, quite simply because there are, as I mentioned, there are indication that decycloserine is not always enhancing treatment effects. They can also harm, in a way, the patient by making by enhancing a different form of learning. So not the extinction learning, but something we call fear memory reconsolidation. So when neuroscientists have clearly identified during the exposure procedure, and extinction is very much linked to exposure, extinction learning is very much linked to exposure therapy, that during the initial phase of the exposure therapy, and also during extinction learning, the fear memory is being reactivated. And as you expose the individual, the animal, or the person repeatedly to the conditioned stimulus without providing the unconditioned stimulus, a new form of learning occurs, which is that the association that there's no shock following conditioned stimulus. So during this early stage of memory reconsolidation, decycloserine also enhances that very process, and it can, for that reason, make things worse. It is very predictable, by the way. We can fairly accurately predict whether or not decycloserine will make things worse or not so far. But still, we still have to figure out a number of details, including how long should the exposure then be, what's the optimal dose of decycloserine, what's the optimal dose of cognitive behavior therapy.
So it can enhance the bad learning, as you said.
That's right.
Is it a solution to give the medicine afterwards? So wait and see if the exposure was successful and then give the medicine.
Yeah, the problem with the decycloserine, that is a very possible solution. We're investigating that hopefully very soon, if NIMH gives us the money to do that. So we are, it is a possibility. The problem is that the drug doesn't, it requires a bit of time to get from your stomach into your brain. And it takes about an hour for it to have the desired effect. If you give it afterwards, there is it will also have probably the desired effect, but in a much weaker form. So that's the only problem.
Yeah. Okay, so looking into the future, looking into the research that's still needed, what would you predict? Is it in about 5 or 10 years that it can be used in therapy?
Yeah, I think it could be used. So already some people are using it. It's a safe and a drug, and some individuals can use it because they can prescribe it off-label. I have to also say, decycloserine is only one drug that opens up a new field of research. We call it translational research. This is not the panacea, not the miracle drug that the field has been waiting for. There are almost certainly other drugs out there, or other molecules out there, that are a lot safer and better tolerated and more effective. We need to, decycloserine opens up a new area of research because it links neuroscience directly with clinical applications, and we know precisely, fairly precisely, how D-cycloserine works. There are many other cognitive enhancers out there that are discussed, yohimbine, cortisol, to name only a few. The problem is that they act on a number of systems, and we don't exactly know why they work. They do work apparently, but we're not exactly sure why they work. With D-cycloserine, we know fairly precisely why it works, if it works.
Yeah, because it's so specific.
Very specific.
Yes, and oxytocin, you're also looking into that. That's a hormone that's very interesting too.
Very interesting too.
Is it promising?
Very promising. The problem is also oxytocin has a very broad-based action, very broad-based, and it's but certainly has some. There's value to investigating it further as a treatment approach.
But it's not your primary focus.
I do investigate it as well, but I'm more excited about D-cycloserine than about oxytocin.
Yeah, you're excited about it. You don't have any financial interests in this medicine?
I wished.
You're sure? You know, stocks? No.
Unfortunately not.
Okay. Well, we'll just have to believe you then. But many people in the audience wondered, like, who is responsible for subscribing this medication? Because in the Netherlands we need a doctor or a psychiatrist to do that. It's the same in the States. So how to solve that problem?
Well, I think it forces treatment providers working more closely together, and this is highly desirable.
Yeah. So that's something you would wish for the future.
Yeah, I think it's very important that we don't use these. I mean, and when you go now, you get. And I also treat clients with a colleague who's a psychiatrist, and every so often we touch base about the patient, and he shares his experience, I share my experience, but there's very little integrated, the integrated approach is very limited, let's put it that way. Yeah. So I think it's highly desirable to force people to work together.
To force them,
I think so.
Stimulate them? How would you do that?
You need to educate each other in their respective disciplines. I think you need both as clinical psychologists, we need to be much more educated about neuroscience and pharmacology, and our psychiatrist colleagues need to be much more educated about cognitive behavioral therapy, neuroscience. So it has to be, nature and disorders do not know boundaries and disciplines, so we need to simply break them down.
Tear down some walls, but that's not so simple.
No, it's not simple.
No, you have a suggestion?
Yeah, well, I think it's all of us need to sort of have an open-minded approach, not to be too close-minded into your own discipline, into your own tradition, rather kind of become curious. You do not need to be an expert. I'm not an expert in fMRI or neuroscience. I don't consider myself an expert. I just know enough to know what I don't know, and it's often enough to be able to make informed decisions and make sense of the world. Yeah. So I think we need to open ourselves up to new fields, to new scientific disciplines.
Okay. So when there will be enough evidence for using this enhancer, do you think therapists will actually use it in the therapy room, or are they maybe a little bit conservative in these matters?
Yeah, it's sort of a difference between what's this is more of a political question. I think there's a sort of a basic, latent, almost hostility among clinical psychologists toward medication, and there's a certain latent arrogance from psychiatrists toward psychotherapists and CBT therapists. So again, I think this is a more political issue that needs to be tackled, but I think as scientists work together closely, that will provide the basis to establish communications and the like. But I think that this organization here is doing obviously a great job of inviting me to share this kind of stuff with you. I'm sure many of you are not overly interested in neuroscience, but I hope you might look into it now a little bit and have an open mind about how to use it in the future. Yeah.
But still there are some questions, there's research to be done, there are some risks in using D-cycloserine.
Oh, of course.
Because it might enhance also the bad learning. Mm-hmm. So what would you expect? How many years do we still need to see this as a regular treatment?
I personally use it occasionally with my clients.
You do?
Absolutely,
Already?
yes. It is. You can use it off-label, but I do not recommend that people go out, buy the pill, and give it to their clients. I do not. And I use it for people who are fairly, with nothing else kind of worked, and I want to see if I can make a dent within. So it's sort of a second approach with if pretty much everything else almost failed. But it's not a, it's what we call in the United States off-label. That means that then it's not FDA approved, but it's safe to use. It is a, it's an FDA approved drug for treating tuberculosis. Again, it's safe for you to use in humans, but it's not approved for anxiety disorders. I'm not encouraging you to use it. I'm not saying that, but it's not. The question to you, from you to me, was how long it takes. There are people who are using it already.
Yeah. So it's not approved, but it's not forbidden.
Yes.
But using it in the therapy room, could it also turn out to be a form of safety behavior?
Yeah. So safety behaviors are. We all know are sort of avoidance strategies, behaviors that to kind of reduce distress associated with, say, exposures to others, and or make people feel less distressed as a result of that. Disaggression does not have any. I forgot to mention that it's an important detail. Does not have any anxiolytic effect. So you can take as much disaggression as you want. You have no increase or decrease in your anxiety. So I can't see how it is used as a safety behavior.
Yeah.
People have not. In fact, you can only use it in situations when you give up your safety behaviors, when you actually expose yourself to whatever is distressing. So in conjunction with any avoidance strategies, disaggression is unlikely to work.
Yeah.
It only works if you give it with effective exposure, and that requires no safety behaviors.
Yeah. Okay. So let's look into the future of the field a bit further. You expect that clinical psychology will merge more and more with psychiatry and neuroscience. Would it be really like a fourth wave coming?
Yeah, so waves come and go, and they make you wet, I see it, and they don't really do much aside from that. So I see our field more as a tree that grows, that develops different branches, that we all share the same trunk. We share the same nutrients of the tree, and we all belong to the same tree, and we're just one branch next to other branches. That's how I see science. I don't see it as a wave.
Yeah.
So is it a new branch? Yeah, I think it is a new branch. And will it be the main branch? A tree does not consist of only one branch. There are lots of branches, and I'm sure there will be other branches that carry more fruit, and I don't want to stretch that example.
You become
too much,
very poetic right now.
But I think it's just one of the branches.
Yes. Okay. And it's here to stay, instead of
so.
the wave that will disappear again. Okay. So, but will neuroscience, like you showed, the fMRI machine, will it also invade the therapy room? It's so expensive. It seems so far away from.
So similar to the example that I gave earlier with the person with skin rash, and the person might send the patient into a laboratory to get tested, and then the results come back, and your providing doctor will then say, well, based on the sample that they examined, we can rule out this, that, and the other thing. So I think we'll have different experts that will concentrate on issues, but it's not that the doctor does not abandon you and say, oh, I have no idea what that is, you should go to this doctor, So I think it informs treatment recommendations and treatment approaches, and I do not see the risk that your therapy will be less effective or less, that you're going to be a less caring doctor by just knowing more about the disorder.
No, instead you predict that it will be more tailor-made, CBT. Right. It will be more personalized by using this. Okay, so coming to an end, what will CBT look like in about 5 to 10 years? Well,
5 to 10 years is not that long of a time frame. So I would say we are probably involved. So I know these neuroscientists already use a lot of our CBT framework. They examine reappraisal strategies and the magnet suppression and so forth. So neuroscientists really do embrace a lot of the same ideas that we have. Yeah. And I think CBT will eventually come to embrace also neuroscience and effective neuroscience, that is. I would hope that that the boundary between pharmacotherapy and CBT will continue to disappear, and we make decisions based on what's best for a given client rather than turf battles that pharmacotherapy is better than CBT and so forth, and basically are using uninformed decisions who should get drug or who should not get a drug or CBT. It's often sort of just a shotgun approach. Let's try this didn't work, let's try that. Yeah. So I think we will need diagnostic tools that are informed by both neuroscience and also pharmacology. One can possibly think of, for example, coming up with a brief test to examine whether D-cycloserine might actually be beneficial for patient X or not, whether exposure can be sufficiently enhanced in this particular patient, and then based on this test, sort of an assay, clinical assay test, we might then assign a patient to the treatment or not. Yeah. So I think we need to rethink the way we group people, and these groups should ultimately lead to better treatment, because we don't really care what we call these groups unless we can there's something good coming out, meaning that we can actually successfully treat people.
Yeah. And we also need to rethink the way we group ourselves as therapists, and with all those boundaries.
That's true.
Yeah. Is that a take-home message, or would you give another take-home message to conclude for the people here in the audience? What's the most important thing they can learn from you today?
I would say keep an open mind. Don't have it so open that your brain falls out, but keep an open mind.
Keep an open mind, and neuroscience is here to stay. Thank you. Thank you so much. Oké, met een open mind, dames en heren, nodig ik u uit om het avondprogramma in te gaan. Er is nog van alles te doen, er is film te zien, er is eten, er is drinken, er is muziek, er is feest. Dus ik wens u daarbij een heel fijne avond toe. Mijn hemel, wat krijgen we nu?
Ja, goedenavond dames en heren. Blijft u vooral nog even zitten, want mijn naam is Daniel en dit is mijn collega Sander. En wij zijn vandaag tijdens de borrel, zeg maar, uw levende wegwijzers. En wij gaan, er is van alles te doen, de borrel begint bijna, maar heeft nog heel even geduld, want Sander gaat vertellen wat er allemaal te doen is. Sander.
Iedereen zit in spanning aan te kijken. Wat gaan we allemaal doen? U heeft heel lang gezeten. Nou, de bedoeling is zo meteen dat jullie eigenlijk achter ons aan gaan lopen. En dan kom je vanzelf in een hartstikke leuk stukje. U komt natuurlijk in het eerste stukje waar u kunt netwerken. Is leuk. Als u dat nog niet heeft gedaan, stel ik ook voor dat u dat zeker even gaat doen. En als u dan nog een stukje verder loopt, dan komt u in een nog grotere zaal. Dan vindt u allerlei standhouders rondom. Die staan te popelen om hun nieuwste producten aan u te laten zien. Kijk, Daniel heeft er al eentje opgezet. Ziet er in één keer een stuk beter uit. Dus ik nodig u uit om ook even langs de stands te gaan. En ik zal even in een vogelvlucht de secties nog eventjes behandelen. Mocht u zin in hebben om nog een sectie te bezoeken. De sectie stemmingstoornissen, die vindt u in zaal 5758. Als u denkt, daar moet ik naartoe. Als u niet weet waar, loopt u straks gezellig achter mij aan. Ik wijs u de weg. De sectie eetstoornissen en obesitas vindt u in zaal 63. En oplossingsgerichte CGT in 5556. Heel veel informatie, hoeft u niet allemaal te onthouden. Komt u straks gewoon naar ons toe. De posterpresentaties, fantastisch, in het genderfoyer. En het genderfoyer is achter de VGCt-stand. Dan hebben we nog uiteraard de VGCt-stand. Daar kunt u terecht voor al uw vragen. En die is uiteraard ook in de genderhal. Dan de beleidsworkshop. Die is ook aan de achterkant van dezelfde stand. Dan kunnen we hardlopen. U vraagt zich af, we kunnen hardlopen. Ja, in ieder geval morgen vroeg. En om vast even een goede warming-up te krijgen, kunt u naar het hardloopcafé. En die vindt u helemaal rechts achter in de hoek, waar ook de standhouders zich bevinden. Als u nou denkt van, ik weet eigenlijk wel heel veel, ik heb heel veel kennis, maar ik weet eigenlijk nog niet zo goed hoe ik dat naar voren moet brengen. Dan stel ik voor, breng een bezoekje aan de pitch yourself. Dan kunt u oefenen, zeg maar, om in 1 minuut jezelf helemaal op de kaart te zetten, zodat iedereen weet wie u bent en waar u voor staat. Bezoek het ook even, hartstikke fantastisch. U ziet er fantastisch uit, is een fotootje waard ook. U kunt een foto maken, kunt u gebruiken voor uw LinkedIn-profiel of gewoon voor uw eigen administratie, kan natuurlijk ook. En dan hebben we ook nog een workshop Virtual Reality by Psychose. Heel erg interessant. In de Baroniezaal van 5 tot 6. En de sectiebijeenkomsten zijn ook van 5 tot 6. En daarnaast, dames en heren, mocht u nog een stukje verder lopen, dan hebben we daar de
Fun Fair, jawel.
En de Fun Fair, dames en heren, ik heb het heel kort samengevat. Ik nodig u uit om zelf een kijkje te nemen. Kort samengevat, kort door de bocht. De kermis van de toekomst. Alle nieuwe technologische ontwikkelingen binnen de CGT. Horen, zien, voelen en ervaren. Meer zeg ik er niet over. Veel plezier alvast. Ik ga het nog even aan jou geven, Daniel. Mocht u zich helemaal verdwaald voelen, zoek ons. Wij zien hetzelfde eruit als de staattafels, dus vergis u niet. Wij zien u vanzelf.
Ja, om nog heel even kort af te ronden. Ga dan dus niet alleen lekker aan de borrel, daar hebben jullie enorm behoefte aan. Of aan de zuurstofbar, die is er ook. Maar verdeel u over de zalen, ga lekker naar de secties, die zijn maar van 5 tot 6. En daarna natuurlijk enorm naar de silent disco vanavond, maar dat komt wel goed. Heel veel plezier en spreek ons aan bij Lopen Rond of zijn op de Segway. Veel plezier dus. Ja.